panel. Okay, we're going to keep going. Let's go to the next one. And we're going to continue with the theme of IOL fixation, and Fabio is going to show us his technique.
That's not my technique, but it's a technique that I try. So can you stop 1 second the video here? I choose this technique because I found during the normal technique of intrascleral IOL fixation several difficulties. The first is this one. Sometimes it happens to me that I bend, break, or lose the haptics when I use the forceps. Can you go on, please? Like in this way, you see, I've lost the haptics and then to take the haptics again. The second one is sometimes it's difficult to put the haptics into the tunnel, the scleral tunnel. I use this cannula to fix it, but it's very difficult. So the idea is to create the two intrascleral tunnel. I use this tube that is used for lacrimal canal, and I create the way of the haptics with the tube. So I pass the two tube into the sclera first, then with the trocar, I do a hole in the sclera. This is the first time that I try this, and it's not so difficult, really. It's a little bit long, but not difficult. Then I pass the tube into the sclera with the forceps. Of course, this is a technique when the eye is aphakic, so you put the IOL from the outside into the eye. So I take the tube outside the eye from the cornea tunnel, using another forceps. Okay, so now you have the way, this is on the other side, of course. And now you just have to put the haptics, the two haptics into the tube. One and the other one. And then you just have to pull the tube, and the haptics just follow the tube and go inside the sclera without traction, without binding, without using any forceps. You just pull it. You never lose the haptics because the suction of the haptics maintain the IOL stable. So from one side and the other, and the two haptics goes inside the sclera. So it's a funny way, a different way. As you know, the IOL into the sclera is very stable for years. So one, and two, on the other side. And once the haptics are in the sclera, you just remove the tubes and the surgery is finished. Okay, you can centrate now and control. Okay, you just remove the tube and the haptics are in the sclera. This is a different way that is quite funny to do.
So these are nasolacrimal tubes that are used for nasolacrimal surgery.
Tube, yes.
Great. And then, so you're using 25 gauge.
Yes.
For this one, and you created the tunnel initially with the trocar.
I only use the trocar, the 25 gauge trocar for the tunnel and for the insertion into the eye.
And that size, did you try with other gauges? 23 and 27,
this is
or is it
no,
perfect for the 25?
It was the first and the only surgery that I performed this way last month. And so now I will do it again and again, and I want to do it better, a little bit better, because once I want to try is to put the IOL with the injector, so to put the tube only in one haptics, inject the IOL without opening all the cornea, and the other haptics, put the tube in the other haptics afterwards, and then pull it.
That's great. Well, you know, there are so many techniques of fixing the intraocular lens, and retina surgeons are more interested in that. And initially, the ARC group described a sutureless tunnel so that they can put it, but there are definitely a learning curve, and especially with smaller gauge and very fine haptics, it's so easy to lose it.
To lose it, to break it, to bind it. So in this way, you don't do that. Probably you have different problems. I have to discover them, but it's quite easy.
Tom, have you tried any of those IOL fixation techniques?
Yeah, I've tried several of those techniques, and it is frustrating to get those haptics to do what you want. One issue we had early on is we started making our sclerotunnels a little bit bigger to get the haptic through it, but then we found out a few months later that it was loose in there and caused some chronic irritation, some chronic scleritis for the patient. So we've made them back smaller again, but then that introduces more problems with the bending. This looks like a very nice technique.
You don't have to give suture, sorry. In this case, because it's 25 gauge, so you don't have to give suture. In other cases, you do a bigger sclerotomy, so you have to suture the sclerotomy. In this case, no, you just put it in.
So one of the great techniques that was presented, also some of the intraocular lenses, they have the 4-point fixation. With the Gore-Tex sutures and so on. And maybe some of you, because especially in Europe and in Japan also, a lot of physicians would do the combined phaco and retinal surgery. And one of the things that is coming out is we have to know the type of intraocular lens that we put, especially retina surgeons. So some of the intraocular lenses are hydrophilic lenses. So if you're a retina surgeon and you're used to put a gas bubble or even air in the eye, if you use a type of intraocular lens that is hydrophilic and you use any air, even a small air bubble that is in contact with the lens, you will get in those cases, even in few months, calcification of the lens. So whatever you use is very important. Most of the lenses we use are hydrophobic, but it's very important to know those hydrophilic lenses, and in most of those cases it's already complicated, so you may expect that you may need an air or a gas bubble in the eye. So we're going to keep moving and go for subretinal PVR. Leo?
Thank you, Temi. Sometimes we can not play with subretinal PVR and just leave it alone, but this is a case where we have retinal detachment, and we decided to go in and perform a transretinal subretinal PVR removal. The first thing is fulfill the eye with a perfluor until the top and just go straight and try to grab directly the strand. You get small hemorrhage, usually in periphery, different in the posterior pole, and you try to pull it, but you may not get it at all at once. So you may leave it like that because you relieve traction, or you can go after and do it in another site. And you can switch instruments. Maybe a serrated one is for that step more strong, but at the same time the movements are very delicate, and in trying to get the thing at least in one piece now. So the PFO gives you a secure retina. It keeps it there and helps you to get the strand, the subretinal PVR. So we do the same. And you see I did the first retinotomy, the PVR just contracted sideways, and you have to do it to take it all. So at the end, we put laser around the retinotomies. This technique would avoid large retinectomies and extensive manipulation.
So this is great. Let's just open it to the panel and see what their preference for treating subretinal PVR. Carsten, how do you peel those?
I would perform it in a similar procedure that you try in the middle of the traction, that you open the retina, you go into the subretinal space, you cut it, that you don't have to open it at too many spaces. I do it bi-manually, that you also can secure a little bit the retina, that the retinal to me is not enlarging, because by pulling sometimes they can be very tense. Mm-hmm. And when they're really in the periphery, sometimes if you remove them, by traction, and some ends remains somewhere in the periphery. They don't intend any more traction on the retina, so they can remain as little particles in the subretinal space.
Fabio, do you peel every subretinal PVR?
No, not every. Not every, but in some cases when I have to peel, one trick is to use two forceps. What I do, one forceps, the crocodile type forceps that you grasp the membrane around the hole, and then you put an Eckert forceps around the membrane to avoid the retinal break. So you use the Eckert forceps to maintain the retina, and then you pull with the other one. So because if you don't put this ring around, you pull and it breaks. So this is a smart idea to use the PFCL, for example, it's another way. But if you don't want to use the PFCL, you just put another Eckert forceps around the membrane and you pull with the other one.
One of the forces we had at Duke, and I still use it, but it's only 20 gauge, and I hope they can manufacture it more. Makmar used to call it the snake forceps, so it has a curve to it, and even if it escapes, you can still have access through the retinotomy, go to the subretinal space, and I remember he was always very excited about, let's get the snake. Please.
Bernard Wolf of Johannesburg is showing a brilliant way of doing this. He left the retina detached, no PFCL, and he introduces a trocar into the subretinal space, sort of post-equatorial, seeing the trocar transretinally from inside wide-angle illumination. And then he takes the forceps under the retina through the trocar and pulls out the strand through the trocar, never ever damaging the retina. It's brilliant.
So this is in case of a retina that is already detached?
Yes. Yeah, like a case like this. I mean, if I see all this damage to the retina, I think Bernard would have done it better.
Anyone would do anything different? Oh, Barbara, go ahead.
Yeah, a question. I would be afraid of using PFCL because if you enlarge the break while pulling, you may have PFCL going under the break. So that's why I usually do it with a detached retina. But the question is, how do you judge when it's the time to remove them? Because most of the time they don't do any harm. Do you judge it under PFCL? Do you judge it under air? Do you judge it with a detached retina?
That's a good point. I started saying that, and this case, in the first time I choose not to remove it. Then I had a detachment, and I judge this is because of the strand. So this is my second surgery. So that's, and I always have that aware of I could enlarge the break and could have PFO under it, but it never happened in the periphery. It's pretty much like that. I have 12 cases now, I guess. But the only concern with this technique, not because of the PFO, but doing it in the posterior pole. The retina in the posterior pole is a little bit thicker and vascularized, and we can have a problem with a hemorrhage, submacular hemorrhage.
Ehab, last comment so we can move on.
Yeah, just we have to remember to always do no harm, because sometimes when we're focused to remove the bands, we end up by doing retinotomies and stuff like that when it's not really needed. Something we always tend to forget with inferior chronic detachment, with the high watermarks and subretinal bands, is just to put a buckle. A buckle will suffice to fix the things. And
well, we can so many ways to relieve the traction. So we got to move on, Barbara. So go ahead.
It's just to remember Cesare. He used to do the spaghetti technique of rolling up the strands, and so I just...
Tom, so refractory macular edema.
Yeah, I'm going to talk today about a case of a patient with Coates disease and 2200 vision in one eye, a gentleman. And he'd gotten numerous lasers to the peripheral macroaneurysms and intravitreal injections, Avastin and anti-VEGF agents, and also got intravitreal steroids. And you can see here sort of the pre-steroid and the post-steroid image, which are basically the same. And the question in a lot of these cases with CME is, what's happening to the initial vasculature, and can we just break the cycle in one event that can then maybe sometimes allow us to treat the patient with less treatment going forward. So here's a situation where I use in about 20% of my cases ICG dye in one of the surgery centers where I can't get anything else. And normally we mix that with D5. We've had a couple situations where they've mixed it with the wrong thing. Originally, we had one that was mixing with sterile water, and it would just float to the top of the eye and wouldn't stain anything. And then we had one case that's relevant to this where they mixed it with D50 instead of using D5, which is a very hypertonic solution that we sometimes put in the infusion fluid in our phakic diabetic patients. So when that happened, the osmotic effect on the retina was dramatic and caused some whitening and completely desiccated the retina under fluid. And the thought on this was maybe we can use that to our advantage. So after that happened, the case I'm going to show next is injection of D50 in the eye. So you can see how heavy it is. It just kind of falls to the back of the eye. There's a little bit of triamcinolone in it, but really not that much. It's mainly just clear fluid, and you can see a little bit already on the top of the retina there. There's some desiccation. That whitening of the retina is the actual retina turning white from the drying effect of the D50 exerting an osmotic effect on the retina. And we weren't sure. Next step in this is probably intraoperative OCT, where we can actually see what sort of anatomic and structural changes we're affecting. But as you can see, the longer we leave that, the more desiccation of the retina occurs. Then we turn the fluid back on to kind of wash it out a little bit. You can see a little bit of the triamcinolone fragments floating around in the eye as the heavy D50, that's a soft tip, is being evacuated under direct aspiration. And you can already see after some of that's being washed out that the retinal whitening is starting to go away as it's replaced by more isotonic infusion fluid, and you sort of get a little bit of a restoration. And when we originally did this, we didn't know, what's the effect going to be? Is it going to affect the anatomy? Is it going to affect the anatomy short-term or long-term? Is it going to lead to any functional benefit to the patient? We did the initial OCT angiography to look at perfusion around the macula to make sure that there was some good vessels in the macula that might allow for this to be effective. So early on, the anatomic response was quite good. After just a couple of days after surgery, there was a noticeable decrease in the macular edema, and we weren't sure how long it would last. We didn't know if there would be a rebound. If it would rebound, it would be even worse. The latest image I have is all the way to the right, and that shows a continued stabilization of the decreased edema. We don't know if it's going to last. We do have a more recent image that was just taken a couple of days ago that seems to show a little bit less edema. It didn't break the cycle entirely. But really, this is just very short results. We did laser a couple of macroaneurysms intraoperatively, which may account for some of this, although he had that macular edema for a considerable amount of time before, despite other laser. So we'd like to get some intraoperative OCT on this to see if it breaks the cycle intraoperatively and to see maybe how long we need to leave it on for to get ideal results. And hopefully we can use this in some of these intractable cases in the future.
It's a great, pretty scary thing. Because when we were mixing the ICG, usually D5W, and the D5W is great because, the ICG looks pretty clean and it falls to the bottom. And the only issue is always the nurse, if they make a mistake and switch it to D50. But now we see the advantage of a D50, so...
Maybe it does.
Anyone had that problem before? By accident, the D50?
Yeah.
Oh, it happened?
Yeah. Well, the retina turns white immediately. I was, what's going on?
So what happened? So you went back and washed it?
Yes.
Did it have any permanent changes?
No, not at all. Surprisingly, it was like maybe 8 years ago, but I was scary what happened. I identified at the time of the surgery, but just goes away. And it was a macular hole, I guess. But it did fine.
Wilson, do you have any comments?
I was just going to say, I think Robert would have said that water only stays in compartments if there's an oncotic load. So you can shift water, but if you've still got macromolecules there to have an oncotic load, it'll come back. So it's not addressing the primary problem.
Anyone has any comments? Or? Okay, we're going to move to the last case. Oh, go ahead, Klaus, please.
In those days when we put blood into macular holes. We dried the eye with air beforehand, and it's been published. Several people got severe visual field defects. So when I see this, it scares me stiffness. So I wonder, is this from a country where you're scared of liability and lawyers?
Yeah, we are. These patients, who have these refractory conditions are usually people who either just want nothing done or they want you to do anything that you can. And, a lot of times if you explain the risk to the procedure to them, then they're willing to undergo it. It's not something you do on your everyday patients, but it's something this patient decided he wanted to try.
If we wait for FDA approval of everything we do, I don't think we're going to advance. So things might look crazy, but yeah. So I'm going to present the last case, and I wanted to share this with everyone. This is the one that it's 1 year out now. And this is a patient that, a high myopic patient that presented to me with multiple detachments before, minus 15 diopter, macular hole schisis, and had detachments before, all done outside Duke, silicone oil removed. And then she's getting recurrent detachment, a very large 1100 micron hole, eccentric fixation. And when I was thinking about going in, I said, I don't think we're going to get any vision back, but I can get a free ILM transplant and put it and cover the hole. And this is exactly what was going on my mind. I went in and we used ICG, but the staphyloma was very deep, and the ICG, all the ILM was peeled completely inside that area, so I had to go way outside, and it's very difficult for the ICG to go very peripheral and stay in. The retina was very thin, so what came to my mind at that point is that all what I need to do is maybe plug that hole. If the retina is very thin, why do I need ILM? I'm just going to get a patch of retina, and it's superiorly, it's going to be an additional retinal hole. Under tamponade, I'm going to do laser. So this is exactly what I did. I put laser, looked at the size of the hole, went in, and then got an area which is a little bit larger than the size of the macular hole, did laser around it initially, and then gradually dissected by manually. So I have a chandelier, and I have forceps and vertical scissors. You can use the pneumatic scissors attached to the machine, or you can use manual scissors. And then I dissected off the bed, had the infusion up initially so we don't get any bleeding, and a few spots of diathermy at the areas of the blood vessels, and bimanually moved it to the fovea. It's very difficult sometimes in high myopia, and many of you have seen all those cases, to know exactly the area of the hole, and sometimes a microscope OCT can really guide you. I use a swept source. I didn't use it initially on those cases, but as you do it, you take one of the forceps outside the eye and put the PFC with the double bore cannula that I use, and it stretches that transplant very nicely in the eye, stretch it over the area of the macular hole, and then I keep adding PFC. So I keep adding PFC so it makes the posterior pole stable, and it can stretch it over the area of the macular hole. It's also very tricky to keep it in place. So you do a high pressure PFC silicone oil exchange so it can stay in place, it doesn't fly or displace. And it's also tricky in very high myopia to remove those last bubbles of PFC because of the location of the staphyloma. Even if you try with the instruments to move the eye so that it can move to the disc, it stays over the staphyloma, and sometimes you have to remove those bubbles very carefully so that you don't remove the transplant. So we published this a few months back, and I presented at Vail. So what? So, I didn't think much of it. You plug the hole, you put retina, plug the hole, another option because you can't have ILM. But what was very surprising to me, the morphological changes in the retina and functionally after we did this. So actually, I did not close the hole. The transplant is the one that closed the hole. So when you look at the OCT gradually, you can see the transplant over that area, and it closes that area of the hole. And then gradually, that patient improved to 20/80. Then I started doing microperimetry to try to understand at that level what's happening in that area and the eccentric fixation. And then because her vision was improving, I decided to remove it. So I removed the oil. So I used a swept source OCT, and as the oil was being removed, I was observing the transplant pre and after oil removal, intra-op live, and it didn't move. It stayed exactly where it is. So it was very exciting to see that morphological change. So if you look at what's happening, as the vision improves, there are morphological changes of the peripheral retina as you move it to the macular area, and that retina started developing outer layers as the vision was improving. Also, I wanted to know exactly where this is coming from, so we have a software we can do co-localization of the microperimetry exactly at the same scans on subsequent visits. And when you look here at the areas and the numbers as it improves, it is at the edge of the old retina, but it is also over the area of the transplant. Also, the multifocal ERG waves were very similar. It's still a crude test, but at least trying to show some functional changes. And because this was very exciting, so I started doing more cases, and that patient comes, I already fixed a macular hole in his good eye, but then we talked about the technique, and he said, why don't you do it on this eye? So this is a very large 1,500 hole, had lost vision, hand motion for more than 5 years, also had multiple detachment, but has baseline geographic atrophy. So I thought the transplant is not going to survive. So what I did instead, I got choroid and retina. So I went to a peripheral area, the only area that is left. He had a lot of scarring, as you see, inside the eye, and I was very successful getting choroid and retina. But the mistake that I made is that I dissected prematurely the retina of the choroid, and it's very difficult to maintain 2 layers inside the eye at the same time over the fovea. He was on Plavix, a lot of complications. But it was very surprising what happened to me. I thought I could get it in place, but he comes post-op day 1. Well, the macular hole is closed, but what is it closed with? It's closed only with choroid. The retina's gone. So the retina did not stay under the oil. It flew inside the eye. So he said, why don't you go in and put it back in place? Like, I'm not going in. He already had a lot of complication. He had some bleeding during the procedure, no time for details. But I was very happy I didn't do this because I observed also something that I haven't seen before. So look at what happened to him gradually. So the choroid is initially at day 1 blocking the hole, and then what is happening to the surrounding retina? You see gradual integration of the choroid into the underlying choroid becoming 1 layer, and then what is happening to the adjacent retina in that 1,500 hole? Look at what's happening to that edge heaping and going in to try to close that area of the hole. And he was solid hand motion at this, so at 6 months, he's clearly count fingers at 6 feet, and this is someone that is very advanced. So I think I started doing more of those cases, some surgical challenges, but it's going to be easier with all of us combined, and many surgeons started doing the technique, and I'm learning from them. So I don't think it's just a plug. You know, I did my PhD in neurobiology, and if someone would come to me and ask me, it's like, this doesn't make sense, I'm not going to do it, but it happened by accident. I think it's a true transplant, and even more, I think there are morphological changes and functional changes. No need for immunosuppression, it's your own tissue, and possibly implication on many macular diseases. So this is the end of the talk. So if any one of the panel or anyone has any questions for any of the cases today. Barbara, do you want to share your experience?
Well, I think it's a wonderful technique, and I was so surprised when I saw your video that I wanted to try in macular atrophy. It was a case that I had not selected for choroidal transplant because the outer retina was damaged. But then I saw your technique, and then I said, well, why not to try? In your case, you have a horizontal integration of the retina, and I was hoping for a vertical integration of the retina. And so I did, but I did it 2 weeks ago, so I can't tell you anything on the functional result. I just have to tell you that the maneuvers are extremely difficult because after placing the patch of choroid, then I cut a patch of retina from the peripheral retina because I didn't want to make one more break into the retina. So first of all, we don't know which kind of cells are there. And, but as far as the technique, it is really difficult to keep in one hand the flap of the retina and then place it exactly in the spots you want, in my case, on top of the choroidal patch, under PFCL, with having a flap of free retina on the side. You know, it's a technique that, of course, needs a lot of development, understanding, first of all, meaning, rationale, but you open the new field, completely new field, and it may have sense.
Yeah, this is what I'm interested about. Not even, I think all of us can do the surgical technique. Eventually we'll find a way, but the biology behind it. What's happening there? There are many hypotheses, the ectopic synaptogenesis.
There could be something like potential, I don't want to say stem cells, but maybe potential new cells rearrangement.
One of the things that was presented at Vail also is that the histopathology of some of the eyes, every one of us is born, and I didn't know this initially, everyone is born with a peripheral zone of cones, dormant cones. So how many know this? And that area or that zone may change in every one of us. So imagine if you have in the future, looking at imaging, if you have adaptive optics, you look at the center, but you have peripheral adaptive optics, and you identify every one of those patients and know where the zone, your backup zone when you're born, where you can get those cells from. I mean, a lot of things are changing. Now when I do primary retinal detachment, I don't do a lot of laser, only the break, because I think I don't want to kill any of those cells. Maybe this is your dormant zone. Maybe this is what you're going to need when you get a detachment, you're 70 or you're 80 and get macular degeneration. So a lot of things are changing. I think the technique is easier now. We're working on an intraocular tree-fine, so we can get retina and choroid. This would make it easier in the future. One thing that I did differently on the last one, instead of silicone oil, so used to seal. So we did the transplant, didn't cut the last area of the transplant, did fluid air exchange, got the transplant, moved it to the fovea, put to seal under the area of the fovea to stick, and then heal on GV on top, and it stayed with C3F8. So I think this is early on. A lot of things need to be done.
But that makes sense if you have a hole, but if you want to repair if you want to do submacular surgery, that's
very
completely
difficult through
different
retinot.
thing. And one more thing that I've done, I'm waiting for the result, is to save a small patch for histology, just to analyze how was that retina that I actually transplanted, and it's different for every patient.
So some of that work was done. If you look at, there is a Swedish group that came to Duke in the early 2001 to 2003. And there are so many papers published in IOVS. So a transgenic pig model of RP, and they transplanted, fetal pig retinas into the retinal space. And you can see on histopathology the integration and the synaptic connection and sprouts that are being made. And last ARVO, there were many papers like this too. So we have a lot of background.
So for next VRS, we'll have a lot of new images to show.
I have a question about the depth in the choroid. The choroid is extremely variable. How did you decide how deep to make your cut? That's my question. My comment as an electrophysiologist earlier in my career, I also noted we did a lot of rabbit studies and monkey studies. Mostly I should refer to the monkey study, which is closer to the human retina. The concentration of cones, it is true, they're there, but they're extremely, extremely few in comparison to the posterior pole.
And this is what I don't know about, is what we're seeing here initially doesn't make sense. And there are different hypotheses. One of them, the ectopic synaptogenesis. One of them, what's happening at the edge, some of the remaining photoreceptors. Hank Kaplan just published recently on a model of RP in a pig also, where you need rods for cones to survive. So is the transplanted rods doing anything to the adjacent cones? About taking the choroid, this was done before. Barbara did many, Grazia Pertili, many have done the RPE choroid. And under visualization, when you take the edge, it's easy to go with the scissors and you can see the plane and you can cut it all the way around too. Yeah?
Just I'm wondering, there is the general surgical rule of don't put two grafts on top together, So these are choroidal graft and retinal graft with no vascular flap-like junctions as well. Just a thought, would this work if you take them together without separating the retina from the choroid and thinking about those as one entity, as a graft or not? Thinking about the procedure.
I think this is the key. That's why I said this is the mistake that I made. Because it was the first case and I wanted to see the edge, I see where the retina and where the choroid is, and he was on Plavix. So in the future, if I'm doing it, I would put PFC, like for the RPE choroid transplant, I would put PFC all on the eye, and I would cut both deep, move both of them as one layer under PFC.
So you tuck them underneath, or you just put them on top?
No, so this is key too, because you don't want to put it completely over the hole. If you look at the picture here, it's very important, like when you think about geographic atrophy and all those cases, to have one edge against the retina and one edge over the flap. And this is the one thing that we don't understand. What's the best positioning for those to survive?
Yeah.